This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on the TAVR procedure. With me today is my co-host, Dr. Mustafa Ahmed, Director of the Interventional and Structural Program at the University of Alabama in Birmingham. And Dr. Ahmed is a specialist in the TAVR procedure. So, Mustafa, tell us a little bit, what is the TAVR procedure?
You know, the TAVR procedure has, in a way, revolutionized cardiology, heart surgery, and intervention as we know it. It's a way of fixing someone's aortic valve in a procedure which now can take, 20 minutes going through the leg, often while the patient is awake, and, with some local numbing medicine, and a procedure where now the patient's with a new aortic valve sitting up within a few hours of the procedure and standing up and walking within a few hours of the procedure, often going home the next day. And the importance of that procedure is, until fairly recently, the only alternative was cracking someone's chest open and replacing the aortic valve while putting them on a heart-lung bypass machine. And why is that so important? Because aortic stenosis, which is what we're treating with the TAVR procedure, which is a tightening of the aortic valve, yes, it's common in the general population, but particularly in the elderly. And as you can imagine, it's not the ideal circumstance for an elderly patient to have to undergo heart valve surgery. And this has provided an absolutely revolutionary alternative for that. And of course, the most famous case in point being Mick Jagger, who recently underwent the TAVR procedure for a tight aortic valve and was able to resume touring and getting back to practice. There's a fairly famous video now of his dancing around and rehearsing literally within weeks of the TAVR procedure. And that just tells you where we were and where we've come in just the last decade or two.
Well, could you tell us a little bit about this? Because obviously TAVR has been around for a long time. I remember years ago, 20 or 30 years ago, TAVR procedures were started in parts of France. But all of a sudden, over the last decade, it's really kind of taken off and it's gone exponentially. And now we're doing TAVR even in patients with moderate risk, even low risk. So what has happened with the history of the development of this technique over the years?
Yeah, so if we go back to literally the 80s, and this problem of having elderly patients, which we couldn't treat, was there. It was a very heartbreaking problem back then. As we all know, extraordinarily healthy 80, 70, 80, 90-year-olds. And many of these patients were very independent. And the thing that would slow them down, leading to tiredness, shortness of breath, fatigue, chest pain, the heart failure symptoms, would be that valve just becoming so tight it wouldn't open and it wouldn't let blood out into the body. So even back at that time, people were thinking, what is a possible treatment to get that valve to start moving and opening again? But the valve becomes calcium, like a rock almost. And so what they thought back then, let's go all the way back to the early 1980s in France, was let's get a balloon. What if we get a balloon, the same type of balloon that the arteries are treated with when we treat a heart attack and stents? But what if we get a balloon, put it in the valve, and blow up that balloon and see if we can just crack that valve open so it starts moving again, and maybe loosen some of that calcium so the 3, usually, and sometimes 2 cusps of the valve can start moving again. So back then, that procedure came along, and one of the first times it was done, very early 1980s, the balloon went in, and it was a fairly complicated way of getting the balloon in, but without having to do heart surgery, the balloon was threaded up to the valve and inflated. And the whole balloon inflated, and the valve started moving more on this particular patient. And everyone was really happy for a little while. They were like, oh my gosh, we've got this patient out of a intensive care unit situation, and we've got the valve moving again. But then, the Achilles heel the whole development of that procedure, which led to its rise and fall, was as quick as you could get the valve open, the valve would become calcified and closed again. It would be the equivalent of taking an old engine which wasn't working, putting a little bit of oil in there, and it worked for a little bit, but the same problems that were there before were there afterwards. And so what that led to was development of, or just the concept of, what if we were to, just like a stent, put a stent on the valve and put that on the balloon, put the balloon in that was before it's inflated, and then when we inflate the balloon, put a stent in there with a valve in it. And so incredibly brilliant engineering, and Dr. Cribier from France and another number of key players from back then started the concept. And let's fast forward to the 1990s, mid 1990s, where they managed to say, let's get one of these stents, and they managed to get it in the patient. And it's remarkable. The way it was delivered then was a lot more difficult than the way it's delivered now most of the time. But they actually managed to go in and, on a patient, get the patient out of the intensive care unit. And the patient didn't live for months and months and months after that, but it was enough to get people realizing, oh my gosh, what if we can take this valve, put it on a balloon, and get one working? And then this whole field exploded. One of the fastest technology-driven revolutions happened, and to where we are today, where there's several valves available. If we want to talk about the history of the procedure itself, what used to be a procedure which took hours of, days of planning, months of planning, the hours to do the procedure, the patient put to sleep, and breathing tubes, and in the intensive care unit for weeks afterwards. If I talk about the ones I've done this week, you walk in, 20 minutes later, you're out the room talking to the patient's family. 5 minutes after that, going back to see the patient who's awake in bed and asking when they can sit up. And that's where that's come. And so it's moving faster than we can even keep up with the technology. And there's a number of different valve types available. And I fully expect that to continue to increase, which is great, because really what it's meant is people that didn't have access to that and couldn't be treated, now you can pretty much treat anyone that's, a reasonable patient to treat, but you can pretty much treat most people with this.
Very good. Let's backtrack a little bit and let's talk about the patient himself. I mean, obviously, you have a patient with aortic stenosis. The first trial, the partners, trial and so forth, they looked at high-risk patient that were not really candidate for surgery. Now we're looking at doing TAVR valve in patients with moderate risk as well as low risk. So how do you define, first of all, can you explain a little bit more about this aortic stenosis? How does it prevent? How does it present? What does the patient feel? And then how do you categorize these patients? What do you consider a patient a high risk versus a low risk?
Great question. So aortic stenosis is the tightening of the valve, and the most common method historically of picking that up was to put a stethoscope on someone and you'll hear a murmur. It's a classic type of aortic stenosis murmur, and we've changed in technology now. We've now got these iPhones with ultrasound machines on, and things have changed. But still, the good old murmur is the best way of picking this up. So someone will hear a murmur and send you for an ultrasound scan, known as an echo. And the echo occurs, and in that echo, you see the aortic valve is typically calcified, small area, tight, and just not opening as well. And so the diagnosis of severe aortic stenosis, and there's a whole spectrum. You can have people that are running on the treadmill and they didn't even know they had it. They have a murmur, you pick it up, and those people you find to have aortic stenosis. But then there's a whole group of patients where, why do you listen to them in the first place? Because they presented to the office with shortness of breath, fatigue, chest pain, a family member noticed them slowing down, and even more alarming, some people present with passing out. And then, of course, the far end of the extreme, people present with sudden death. And so there's this whole spectrum of people available, spectrum of people that have the aortic stenosis and present very differently clinically. And sometimes it's difficult to tell. You can have severe people with no symptoms and severe people with very, very severe symptoms. Interestingly, on the people with no symptoms, you'll often find if you were to exercise or if you were to actually formally quantitate the amount of exercise they can do, it will often be reduced compared to someone typically for their age group or or what they're doing, or you'll find that over the last 6 months, year, 2 years, they've declined. And remember, aortic stenosis can often take years and years and years to develop. It's not something which just one day you have it, you didn't the day before. It's something which over time is a progressive disease, and often you'll pick it up at a milder or a moderate stage and follow it with echocardiography, follow it with symptoms, and go from there. And then you ask the question about who's high risk and who's not high risk. So that comes down to surgery. Who's a high risk surgical candidate? The old open heart surgery. So low risk is 50, 60s, 70, not many other comorbidities or problems, so not many other medical problems, relatively good, constitution and functional status, and they've been going along, and really you could operate on them. And when you say low risk, you mean we could get them through an open heart surgery with less than 1 to 2% of risk. And then moderate risk. So those are those people a little bit older, maybe 70s to 80s, maybe have had a previous heart surgery before, maybe have a, very heavy or have a slightly weak heart. And we use some scoring methods. There's a few classic scoring methods, but really it's the eyeball test and the clinical just reasoning of the whole situation. And they're a bit moderate. Then high risk, of course, is those, 80s, 90s, heart surgery before, weak heart, kidney failure, liver failure, multiple other medical conditions where you say there's just on no planet is it a good idea to operate on that person. So they would be a high risk for an operation. So when we talk about risk profile for patients with aortic stenosis, we're typically talking what is their risk of undergoing an open heart surgery.
Very good. So a lot of patients are totally asymptomatic. As a matter of fact, aortic stenosis is also called the silent killer. But once you develop symptoms, the shortness of breath, the fatigue, the chest pain, and the passing out spells, the prognosis is very dire, and actually mortality is really high. And for this reason, once a patient develops shortness of breath and chest pain, we need to really make sure that we work up these patients and do the appropriate, physical exam as well as followed by the echocardiogram, because symptoms do matter. And you're right. Why is that a patient will have a critical valve and have no symptoms whatsoever, at least, with their normal activity, and some others have significant symptoms? Listening to the patient can make a big difference in their survival.
Yeah, if you ask where this field's going and some of the recent developments, one of the early things you're taught in medical school and cardiology is, take a patient with symptomatic valve disease very seriously, because that you've entered a red flag zone where if you don't do something in a relatively timely fashion, you'll lose that patient. But in the old days, it was okay. What if someone hasn't got symptoms? Their risk of maybe developing an event every year may be in the low few percent. So you say, well, I don't want to just do a heart surgery on someone that's got a few percent risk of an event per year. But, as time progresses and evidence accumulates, how do we get that down to next to zero? How do we get it down to where we almost can eliminate risk? But then we need a procedure that has no risk. And that's where the interest in the TAVR procedure comes. So lots of research has been done now and shows those asymptomatic patients, when you look at MRI scans, when you look at CT scans and echoes, there is evidence of damage. You just can't see it in the symptom status, but there's thicker heart. There's more development of a process called fibrosis and thickening of the muscle and the interstitial, matrix that holds the heart together. And there's thickening of the heart, which doesn't allow it to relax as well. And this doesn't always come back afterwards, which could lead to increased risk of heart failure in the future. So over the time, I think we're going to see even asymptomatic patients, and there's actual early TAVR, and then there's another 1 or 2 trials ongoing right now, which are actually looking at those patients that are asymptomatic to see, would it actually be better to go ahead and treat it? And of course, we can't just say yes for now. We need to accumulate that evidence, which is happening. But most of us in the field fully see it going in that direction.
It's pretty difficult to convince a patient to undergo a procedure when they're feeling well. And this is where you stress the evidence of trying to get maybe a little bit more data. And sometimes putting that patient on the treadmill, it makes them realize that, well, their exercise capacity was not as great as they thought. But sometimes you have these patients that are really completely asymptomatic. So obviously more research is done, because once they start decompensating, it's very difficult to save them.
Yeah.
So let's say you have this patient, I have critical aortic stenosis. What should they expect when they undergo this workup for this TAVR? I mean, is this something you can do just in a day or two? Or what is the process of getting the patient through a TAVR procedure?
So most of the time, these patients will be referred by other cardiologists who have done some of the workup. And I'd say about 20-25% of the time, they come through a primary care doctor straight to a valve clinic. The valve clinic is the new flourishing frontier in heart disease, and valve clinics are now becoming a primary place to go for assessment and treatment of valve disease. So how do they get to the valve clinic? Usually by the time they come there, they have had an echo. So you see that echo and you're looking for certain parameters. You're looking for, a velocity across the valve to be high, suggestive of a tightening. You're looking for a gradient, which is telling you the pressure difference before and after the valve. And all these things are markers of severity, which ultimately give you a valve area. Now, the normal valve area might be, 2.5 plus centimeters squared. And moderate might be when you get down to, 1.25 to 2, somewhere like that. It's never good to have full cutoffs for these things, but somewhere around there. But once you get down towards 1 centimeter squared and less, that is severe. So that valve, which is usually double or triple that size, is really becoming a tightening. And sometimes we see it become almost pinhole-like. So the patient comes with that echo, then we need to rule out a couple of things. So we'll typically look at their arteries and make sure they don't have coronary artery disease. That is usually done by the form of an angiogram, where a heart catheterization is done and we look for blockages. That's important. We talked about asymptomatic patients before, but what if you've got 3 blockages? Suddenly you've got critical disease and you've got 3 blockages, and you probably need to treat that. That's also important because, as we'll talk about, I'm sure, a little later, what is the decision tree between people going for surgery? Surgery is still very much alive and a very important way of treating this in the world. And what are the factors that make up that decision? Then we'll look at other things. So we're looking at patients' risk profile. So we'll work out risk scores for surgery. We'll get lung function tests, because that'll be part of the risk score for surgery. We'll have people walk, usually a 6-minute walk test, to see what kind of symptoms they're at. We'll record people's symptoms fairly closely. And then other things which now help the workup, a CT scan, usually with some contrast given to find out which is the best way to go for that valve. But more importantly, I remember 10 years ago when we would do a valve and it was this, oh my gosh, it was like, which size of valve should we put in? This is going to be a really big decision. Let's all sit in a room and get our software out and have some guess at this. I mean, that science has progressed incredibly to where the CT scans are to the millimeter. It is now expected now that, you can almost perfect that valve size. And why? When you put the valve in, you do not want leak. You do not want it too big. You don't want to cause complications. And more importantly, on that CT scan, you can see pitfalls. You can see things that can make that procedure either more dangerous or less dangerous, which might inform your decision to do surgery or a TAVR procedure afterwards.
So you have all these tests to undergo, and then you have a meeting, I guess, with the surgeons, and you have you still have second opinion from the surgeons, and is this afterward kind of discussed with the patient? What is the process in the decision making? I
think that is one of the most important questions I think we're going to address today. And the answer to the question is just 2 words: heart team. And so every patient that now is treated for valve disease, it doesn't matter whether it's a 19-year-old with a mitral valve or whether it's an 85-year-old with an aortic valve, all these treatment decisions should be made through a heart team, which means surgical specialists, interventional specialists, structural heart disease specialists, imaging specialists, and other allied specialists get together and ask what is best for that individual patient and why. When you talked about the trials a while ago, so when we talk about the partner trial and the core valve trial for the 2 main valves used today, those trials first came out and they were done on very high-risk people. And people were like, there's no point even. Some people didn't think there was a point in doing those trials because they were like, well, those people are so high risk. What are we going to prove here? And what was seen then was landmark. I mean, there was this incredible survival advantage for people undergoing now the transcatheter aortic valve procedure, the TAVR procedure versus no procedure. So what we realized is we've got to try something. We found something. We can try it and it works. So then suddenly they said, you know what, let's go head to head against surgery for that high risk population. And against surgery, the TAVR procedure came out with less morbidity, so less complications for the patient, a higher likelihood of survival, more chance of coming through and doing well over the long term and recovering meaningfully without, avoiding that ICU and the rest of the stay. Also looking at important outcomes like death, stroke, vascular complications and such. But TAVR was the clear winner then. So then people came along and said, well, we've done it in the high risk population. What about the moderate risk population? What about the people at intermediate risk? So then trials were done again, and landmark trials, because you've got to remember, before 10 years ago, there was essentially zero, almost, maybe one class 1 recommendation in heart valve disease, which means underlined by good evidence. But this TAVR procedures changed that completely. The evidence that then accumulated for the moderate risk patients showed again, TAVR can be done well, it's durable results, and the patients will do better. So then a more contentious trial came along, which is very important to discuss, which are the low-risk trials, the Partner 3 and the Evolute trials for patients at low risk for surgery. So you could probably take them and get through a surgery with just, 2% risk or less. And what would happen? So then those trials just came out, probably, we're talking less than a year, basically, since those trials have come out. And what they showed is these things are comparable. There is potentially even an early decreased chance of stroke and a chance of doing better. But importantly, over the follow-up period, there was no large difference seen. And that showed us, one, the gold standard treatment of surgery was still a gold standard treatment because the outcomes were great. But what drove the excitement was suddenly the TAVR procedure got into the game of low risk. But with that trial comes a great responsibility. And it's probably one of the most misinterpreted trials by valve teams, because once that was FDA approved, which it was, it's important to know the nuances of those trials. So what we need to know as a heart team, why is that heart team so important? And people were like, TAVR procedure is going to come along and there's going to be no need for any surgeons anymore. And no need. Well, actually, what we find, and we're one of the highest volume centers, in the US and the world, and what we found is the mixture of both, getting that surgeon, cardiologist, interventionist all together, even performing the procedure together, that clearly, in our mind, drives the best outcome and decision making for that patient, because there's no single stakeholder in that which benefits from either way. It's just the patient at the center. Why is that important at low risk? So when you take a low risk patient, I want you to imagine a 70-year-old, right? That patient is low risk. You could take them for an operation. And surgeons will tell you they've been operating on those patients for years, decades, and they've done just great. But in the trials of low risk that were done, many, many patients were excluded. So before doing low risk, we have to know who was excluded. That's based on anatomy. It's based on patient profile. It's based on valve sizing. It's based on calcium patterns. It's based on features of the CT scan, such as the outflow tract in the aorta. It's based on the size of the aorta. And so now, where some people are interpreting that as one size fits all, because there is no patient that wants to come in and hear they're going to have open heart surgery. But more importantly, you don't want to just do something because a patient comes in and says, oh yeah, that's what I want and that's what I'm having, without at least explaining the risks, benefits, and pitfalls to that approach. So there's still many patients, we can discuss this if you want, but there's still many patients who are low risk that really, really should not be having the TAVR procedure, but they should strongly consider surgical procedure, because there's patients that we're going to be faced with a dilemma. Someone told me once, a surgeon that I trained with, that every time you do a procedure on someone, you're introducing a disease. And so be careful. When you introduce that disease into someone, you need to know the natural history of the disease. And the natural history of the surgical procedure is very well known for decades. The natural history of the TAVR procedure is being defined in real time. It is very reassuring how it's playing out, but the long-term history of it's unknown. So we have to be very careful when we're taking our younger patients who may need 1, 2, 3 more procedures in the future, and make sure we're doing the right thing that leaves them other options, rather than, hey, this seemed a good idea now, but in the future we've kind of left you in a little bit of trouble with the decision making. So that responsibility comes with it.
Well, I think that the heart team really started with the valve clinics, and in the TAVR procedure, really getting the surgeons and the interventional cardiologists to kind of work together, really panned out of the TAVR and really getting what is the best for the patient. There is a bit of reluctance among cardiologists to obviously send a patient for a TAVR procedure if that patient is only maybe in their 60s, knowing that we don't know exactly at this time the long-term, how long do they last, these valves? They last 10 years, they last 15 years. What is the data showing, so far on what we have? And I guess if we are doing a TAVR procedure in the low-risk population, we need to make sure that these patients are entered in some protocol where, they are followed on a regular basis. And because it's obviously not for everyone, as you mentioned. Do we have, what kind of long-term data do we have on the current TAVR valve, even though they come out with new valves, every year almost?
Reassuring is the data year on year gets a little more reassuring. And I would say, 6, 7, 8 years now, there's good demonstrable data of durability. Nothing is perfect. No surgical valve is perfect that is put in. No bioprosthetic TAVR valve is perfect. They are. When you put a surgical valve in a younger patient, it is more likely than an older patient, you are going to have a quicker tightening or degeneration of that valve again. So the younger the patient, the more that process is. It's thought to be potentially due to immune-related factors or other. What we've learned from the older population is the bioprosthetics versus the surgical bioprosthetic and the TAVR are very comparable. What can happen over time to these valves? We just do not want early degeneration. So thickening of the leaflets, clot development on the leaflets, tightening of the valve, leaks around the valve. Those are all things we have to watch for. In the low-risk trials, again, remember, this was hard to get in that trial. So it's not all low-risk patients, but patients that are low-risk, felt to be the kind of candidates that were considered for those trials for good reason. The intermediate term, so few-year data now is reassuring. What's also reassuring is the engineering that's going into these heart valves is just incredible. And year upon year, new generations of valves are coming out. And we've not had a newer generation of valve which has been felt to be, higher risk than previous generations. Each one is felt to be more durable, undergoes rigorous testing, and have advantages. But there is that crossroads now. And I think the next few years is going to tell us, as we gather that data, we know early on for the first few years in low risk, there's no difference. We need to, like you said, meticulously follow those patients and make sure at year 6, 7, 8, 9, 10, 11, 12, the natural history of a bioprosthetic valve, we need to make sure those patients are followed and any early signals caught ahead of time. And so that's being watched closely and really, really important. And cardiologists, unless you're sending to a heart team, where a surgeon, a cardiologist, and people with, that patient's interest at mind, rather than just doing, a TAVR or whatever it is, that hopefully will reassure many of those sending that discussion is being had. Discussions around the TAVR procedure, they were simple at the time of high risk and intermediate risk. It was like, hey, this does well, and you were at risk anyway of having heart surgery. I will tell you, it's when low risk got approved, we were finding ourselves in rooms with patients for half an hour just for that discussion. I'm talking about half an hour discussion of the risks, the benefits. We've even made teaching aids and videos just to say, this is the known, this is the unknown. You're going to have to help us in the decision. Patients often, they have a lot of trust in doctors, and doctors will say, this is best for you. This is not the case with TAVR, the low risk TAVR. This is the advantages of this approach. These are the advantages of this approach. These are the unknowns. We want you to join us in an informed decision-making, shared decision-making process. And some patients will say, you are not cracking my chest open for this, and this reason, and it's not happening, and we understand, and okay. And if it's, if we think it's still a good idea, we'll do it. But some patients are like, I don't like the little bit of unknown there, and I like that I'm a very low-risk surgical candidate, and that's what I want to have. I'm sure we talked about Mick Jagger before, but I'm sure in his case, I'm sure he could have undergone surgery with very low risk. But at the same time was thinking, I need to be, rehearsing, back on tour, back doing my thing. extraordinarily active within weeks. And so at that point, it was seen as, I want to get back on my feet and be able to be extraordinarily mobile very quickly. So I went for the TAVR procedure. And another thing is important is, what is a natural history, right? So when we have an 80, 90-year-old, we're not necessarily saying, hey, how do I make you live till 200? That's not the goal here. The goal is to increase quality of life. And ideally with that, a survival benefit. But when you have a younger patient, when you're 70, I still remind people, well, how many people are still around at 85 and worried about a decision on a heart valve? It's enough to where if the patient's very healthy. But if you're not a very healthy 70-year-old, we don't need to complicate as much the decision-making process by saying, oh, well, what are we going to do when you're 85? I mean, what a golden bonus if we can get you to 85 and we have that problem then. That's the problem at that time. So the more experience we have with these valves, the more we learn, the more you can really inform the decision-making process. It's an experiential thing gained over time, and a lot of evidence, trials, and data-driven, and a lot of unknown as well, which is that really low-risk profile. But there is still many patients that should undergo surgery and should be seen in a place where surgeons are capable of doing more complex surgery, like aortic dilatation. If your aorta is big and you've got a bicuspid valve, just because your local team can do a TAVR and your surgeon isn't adept at doing a root replacement, that doesn't mean you should have a TAVR. That means you should be sent somewhere where patients are routinely undergoing root replacement and bicuspid valve surgery, and if they've got a lot of particularly dangerous patterns of calcium, which may leave them with leak or may leave them with those patients, again, if they're low risk, should be undergoing surgery, and your local surgical expertise should not govern that. Your entire heart team should govern that, and referral to centers of excellence dealing with that should be the norm.
So I like the fact that you talk about 70 and 75-year-old as young patients. I mean, it's a different world. Your world of the TAVR and aortic stenosis is a world that starts maybe in their 70s in a lot of cases, particularly for the degenerative type of aortic stenosis that we see most frequently. But, what about if you have a congenital valve, a bicuspid valve? Is TAVR still a good option? If you have a lot of aortic insufficiency combined with this aortic stenosis, is it still a good option?
Bicuspid valve is the less common type of valve, which means 2 leaflets instead of 3 of the aortic valve. So most people have 3. Calcium develops over time. That's the predominant mechanism of aortic stenosis that we see. But bicuspid is still a fairly sizable population, and that develops early. You're born with 2 cusps of the aortic valve in those patients. And over time, those degenerate quicker, sometimes tightening, sometimes leak. And so what do you do if they develop a leak over time? That is less well studied. Here's what we know about bicuspid aortic stenosis. We can treat that patient. We can treat them fairly well with TAVR. The data is, minimal compared to the, wealth of data we have in tricuspid aortic stenosis. But say you have a high risk or a, intermediate to high risk bicuspid aortic valve patient, we don't think twice. As long as the CT scan anatomy is amenable and other factors of that patient make sense for it to happen, we can actually get very good results. That's really progressed over time with the sizing algorithms. Very little leak and a good result. And we're learning how to get good hemodynamic results with higher implantations. And so that feels advancing, and we don't think twice. Again, high risk patient, intermediate risk to high risk patient, bicuspid aortic valve, yes, you can do it well, and durability data looks good over time. But, low risk bicuspid patients were excluded from the TAVR trials. They often have large aortas, and it should not be common practice to just go ahead and say, I'm going to take my 65-year-old with a bicuspid aortic valve and or aortic root dilatation. I mean, if that was me, I'd be chancing my hand with surgery just because it works well. And we can talk about that in a little bit, but there is, once you've had surgery, you can still have a TAVR valve in another field called a valve-in-valve situation. You'd rather have a valve-in-valve type situation when that patient's 75, 80, rather than have a TAVR inside a bicuspid with potential issues around that and then put another one in. And so bicuspid can be treated well in experienced centers with the current valve platforms available, but still TAVR is not the treatment of choice for a low risk, youngish, good surgical candidate bicuspid aortic valve patient. That is surgery.
The aortic insufficiency was also excluded from these trials. Are there some patients that you feel that you could treat with TAVR in a situation where the valve is primarily leaking?
Yeah, so aortic insufficiency, like Dr. Bouchard is saying, is where the valve is leaking, also known as aortic regurgitation. There's a typical difference between those valves and the stenosis valves, which is that the calcium isn't there. Now, sometimes you have mixed valves. So if you have a valve which is still pretty calcified but leaking badly but still tight, you can go ahead and, in most cases, treat those with TAVR in the appropriate situation without problem. When you have just leakiness, it becomes a more complex problem, and treatment of that is still off-label. So we do those. We've done a good number of those. But really, it's not approved, and it means we've got no other way of treating that patient. They're in no way a surgical candidate. They will die if we try that, and we have to try something so we can make the TAVR valve work. That comes down to sizing. It comes down to features of the aorta and the aortic valve and the ability to deliver the valve. But yes, we've delivered several of those safely, but that means really being assured of sizing. A good example of that is we've done, pediatric patients from Children's Hospital who have had multiple surgeries before and congenital, and they have a leak. But the good thing about those patients is they often don't have very large aortas. When you get into patients that are 80 and 90, if the aorta is small enough to handle it, you can put it in and be fine in most cases. But in the larger aortas, where you're getting on, the valve size is just reaching the upper limits, there's still a lot of unknown and risk to doing that. There is development of platforms, but as you can imagine, this is only a few % of all people presenting with aortic stenosis. So the research, development, and interest in those has not mirrored the typical TAVR procedure, just because industry doesn't have as much skin in the game to want to push that field along. But there is one or two dedicated platforms which may become solutions for that, still a number of years out from being mainstream.
We talked about the risk of performing the TAVR. Could you expand a little bit on this, Mustafa?
Yeah, so you know what, let's talk through a TAVR procedure and talk through the risks at each point. So when we talk to the patient beforehand, we say, this is the procedure you're going to undergo, and your chance of death should be, less than around 1%, particularly in lower risk, and less than a few % in the higher risk. And we talk about that beforehand. We also talk about the potential for needing a pacemaker and another number of complications. We also tell them that the overwhelming chances with the planning done nowadays and the device delivery, the procedure itself is still a relatively low risk procedure. In most cases, there's still, of course, the higher risk cases that come along. So when we start the procedure, the patient will go into the room, and it'll take about 20 minutes to get them ready. Anesthesia will maybe put a line in so they can monitor during the procedure and give some light sedation. We used to go to sleep for all those patients. We hardly go to sleep at all now. In fact, very, very, very seldom, even in the highest risk patients, do we go to sleep for the procedure. We're awake. I had a procedure we did last week where the patient right at the end was like, hey, I think that went well. How did it go? I'm still amazed every time we do it. I'm like, oh, yeah, that went fine. Thanks for asking.
Endorsement of the patient.
I mean, it's amazing. They're just calmly there throughout the procedure. It's not a traumatic experience. It's well handled. And so most cases, 95% plus cases will go in the leg, in the artery in the groin. So we'll take some numbing medicine and numb up the leg, and then we'll insert a tube through which we work. So the first potential complication that could happen is there. What if you cause damage to the artery on the way in? The chance of that damage is typically less than 5 to 6%. And you can pick that up on the CT scan beforehand. You can use meticulous techniques and ultrasound to access the vessel. And now we use these stitches that we put in without having to cut the patient. So they're called these ProGlide type stitches, which can go in, and afterwards we can quickly close them at the end. So there's your first potential chance for complication. But your CT scan should have shown you beforehand whether you can get up through the leg or not. So we go up through the leg and we put a wire through the aortic valve. Now, anytime you are messing around inside the heart, doing a procedure, putting wires, there's a chance of a stroke. Some people would argue anytime at all you do a procedure like that, whether it's surgical or through a catheter, if you did an MRI scan afterwards, there's no way you don't see something. The good news is clinical strokes are very rare still in the TAVR world. Less than 1 to 2% do they happen. Occasionally, when there's a lot of mobile type calcium in the valve, we can use something called an embolic protection device. We don't use them routinely right now. Trials are still ongoing to see if they are useful or not, but those are other options. So then a wire is passed up through the heart, and you go through the valve using various techniques, and you take this valve, you pass it all the way up through the aorta, around the arch and of the heart, and on the MyHeart.net images, you'll be able to see videos taking you through the whole procedure on the TAVR procedure article. And so then we go into the valve, and we inflate the valve or we expand the valve, depending on which one used. There's a very small risk, which again should be mitigated by the meticulous planning, of damage to the valve and the areas around it and leak into the heart. And those are pretty catastrophic if they happen. But again, those are very, very rarely seen if meticulous planning is done. So once the valve is expanded into place, this is about 15 minutes after starting, 20 minutes after starting the procedure, we pull the apparatus out, and you want to make sure there's no fluid around the heart. Again, the chance of that happening in effusion or damage to the heart structure itself is very, very low. But if it is, you can pick it up there and take care of it. Once the valve is expanded in place, it can often go on the electrical system of the heart. So it can push onto the electrical system and sometimes need people leaving a pacemaker. The rate of that is anywhere between 5-6% to 15%, depending on trials and techniques used. Over time, we're learning how to do that. But if it comes between putting a valve in the right way, doing it well, and needing a pacemaker, that's okay. You're alive, you've got a functioning valve, you need a pacemaker, that's absolutely fine. But there are techniques to use to where those that don't need them can be avoided. And then everything is taken out. The tubes and the wires are taken out of the body, and the leg artery is closed. And so then the potential complications that could have happened are vascular access complications from where you go in, and bleeding and disruption and those things, damage to the heart structures, damage to the aorta structures, potential chance of a stroke. You use contrast in procedures, so there's a small chance of kidney dysfunction. The good news is, inexperienced TAVR centers, these complications are paid absolutely meticulous attention to. The more you do, the better you get at, mitigating those risks. And they're tracked closely in registries that are followed throughout the country. So when you're having a TAVR procedure in place, you can, by all means, ask your center or where you go, what is your experience with this? What is your experience with complications? What is your experience with dealing with it? What is your pacemaker rate? What is your stroke rate? What is your vascular complication rate? What is your death rate? How many have you done? How many, these are very, very important questions to ask, but all TAVR teams should be obsessed with those outcomes. So those are those complications that can happen. The risk of them is still very, very low. You should be able to pick up the risk of those by pre-procedural meticulous planning. And if they happen, ideally, most of those complications can be dealt with. To my mind, the most devastating complications that can happen are death, stroke. They're the ones where large strokes. Again, you can hardly remember the ones that have happened. We have experience of over thousands, and you can still remember the very, very occasional time, but that you can't get over as well. Having said that, now many of us have stroke centers where you can have someone, if something were to happen and a stroke would happen, you can go in and take care of that immediately if you have stroke specialists on hand that are invasive. And no matter what you do in any procedure, there'll always be a very, very low chance of a major, major complication. That's the nature of what's being done, but it should still be very, very low.
Well, you have a very good article in MyHeart.net entitled "The TAVR, the New Heart Valve Replacing Open Heart Surgery." I can't believe it was in 2015.
Can you believe that? I mean, my gosh, I've got to go and update lots of that. I mean, so much has changed between then and now. I mean, it's hard to keep up with, right?
You even have a part 2, actually, which it shows very nicely how the valve is deployed, and I think that will help the patient a lot. So the patient has had the procedure, and when do they go home, and do they go home on any particular medication?
It used to be to where patients would spend a week, in the intensive care unit and home, and then go home, and we're going to fast forward that whole time. So the key is to get that right before the procedure. If you have someone that is able to function but needs a bit of prehabilitation, that is okay to do before the valve. And that's important because it all has to do with length of stay. And there's almost no doubt the quicker you can get someone home afterwards, within reason, using sensible decision-making, the better they're going to do and the better they've tolerated the procedure. So after the procedure, you'll typically go, I'm going to talk about our institution, just in terms of how it's done. After the procedure, you typically go and be monitored in a monitoring type of bay for 1 to 2 hours. Just make sure there's no complication with the legs. Just make sure there's no early complication where we would need to bring you back to the operating suite or the cath lab earlier. And after that, what used to be sending patients to the unit, we no longer do. It's very, very rare. Patients go to the floor, like the same kind of floor if you were just coming in with any type of normal admission. And within 6 hours of the procedure, we want you sitting in a chair. Within 6 to 8 hours, we want you up, walking. And ideally, we want you complaining that you want to go home the next morning of the procedure. And so things that will stop you going home the next day are, what if you need a pacemaker? You may need to stay another day, because you don't just want to put a pacemaker in on the table just because it will send someone home quicker. It's okay to wait 36, 48 hours afterwards to see. Again, this is not all patients. This is a relative minority of patients, but it's okay to wait and see, because you might recover your conduction system and not need one. So, we work with our electrophysiology colleagues carefully to ensure no pacemaker is needed afterwards. And if it is, it's usually done on the second day, and you can still go home on day 2 or 3. We've now started a protocol, which we actually have some research work coming out, and led by Dr. Préjean over at UAB, a wonderful research paper looking at for all the different valve types next day, discharge. And I can tell you now, we are more often than not having people go home the next day anyway. We're also figuring out, though, who are those patients that can really, really safely be sent home, looking at them at 30 days, looking at them at 1 year, looking at them a number of different things about how they went home to make sure that's safe. And the way it's panning out, this is working out very well. But if you want that to happen, it's like a clock that starts the second after the procedure. Meticulous removal of lines, getting the patient up, early breathing kind of stuff on the table, anesthesia, closely monitoring them afterwards to make sure that there's no difficulty, early transition to a floor and not a unit, sitting up very early, mobilizing, having a PT and OT specialist see them at that time, lines, tubes, all that other stuff out, and a real close working relationship with the family and the patient for expectations as to what is expected and why. And once you do all that, you can turn what's routinely 4, 5, 6 days into 1 day. Excitingly, we've just put a protocol in looking at same day. So we're hoping to, within a year, we've got a very exciting project going on where you take patients and do them early, follow them meticulously through the day. And again, I want to be responsible and say this is part of a very carefully organized research protocol in an experience center. But can you go home the same day of the TAVR procedure? And then we would have gone, that'll be the full story told from decades ago, open heart, month in a hospital, might make it home on op 2. Hey, we did it while you were awake and talking, and we sent you home the same day. I mean, wouldn't that be a wonderful story? But again, before that becomes routine, got to collect data, got to make it safe, and only do it on the people where you think there's a benefit for them.
The question, Mustafa, is do they move like Jagger?
We do the test, the Jagger test, prior to discharge, to ensure they can do all those routines. And if not, we'll be very, very disappointed.
Any medication?
Specific for the valve itself. So, many patients have already had stents and they already have arrhythmias and they already had this. So say you were on aspirin before, or aspirin and Plavix before, or Coumadin, or, one of these newer blood thinning agents, you can continue to take those. Say someone was on no medication and came in for a valve procedure. What we know is that there is a risk over time, right, of any bioprosthetic valve developing some kind of thickening on the leaflets. Not necessarily the kind of clot that will cause a stroke, but the kind of clot that will prevent the leaflets moving as well and tightening. So data is being collected in many places right now to find out what the optimal regimen is. A year or two ago, we got excited when there was a potential signal of less leaflet issues with people who took much stronger blood thinners. But then what we found out is, you can have an increased chance of bleed with those. So right now, the standard is if you're on a stronger blood thinner beforehand, we'll continue it afterwards. If not, we'll do aspirin and Plavix. The Plavix for 3 to 6 months, sometimes a little longer, and the aspirin lifelong after that. And most patients are seen at a week. They're seen at a month. We're watching the echo closely. If there's any development of high gradients or something that would make us think the valve is degenerating prematurely, we will start stronger blood thinner, and that will usually reverse the process. So in terms of the blood thinning medications, those are watched closely. In terms of other medications, patients that are in heart failure with a low heart function will still work to optimize those medications. But other than that, no specific medications for the valve itself, other than the platelet and blood thinning medications where appropriate.
So let's say I've had my TAVR valve, and should I expect, what kind of follow-up do we expect? Do you follow these patients once a year with echo? Do you just kind of monitor symptoms afterward? And what happens if my valve kind of closes again? What are my options at that time?
Great. So firstly, very rare, and that should be picked up by others in the follow-up process. Most patients come from a cardiologist, so any patient that's been with a cardiologist will continue routine care. And most cardiologists now are becoming very adept with the TAVR procedure. The conversations I used to have 6, 7, 8 years ago are very different now, where people have just learned so much. It's become a routine part of cardiology, as it's on the regular cardiology board exams even. I mean, that tells you how much of a mainstay the TAVR procedure has become. You'll see the patient straight after the procedure itself. The day one, you will have an echo. And that will usually pick up any very, very early problems, but extraordinarily rare. But if there's something, that's where you want to pick it up. And then you'll see the patient at a week, and you'll tell people normally, you should start to feel better by then. Those that were more debilitated beforehand might take a little bit longer, and those that need rehab or some kind of physical therapy demands afterwards may take a little longer to notice that. But typically you'll see a very early improvement in symptoms for those patients that clearly had the aortic stenosis underlying their presentation in the first place. Then at 1 month, you'll see the patient and you'll do an echo again. We in our center do all our echoes ourselves. And the reason is we have the same dedicated sonographers doing them. And we just think the data is clean for the registry. So there's a registry called the TVT registry, which you have to put a number of variables in it. When the procedure happens, before, and then the echo before discharge, some things at the week, the 1 month, and the 1 year. And then we actually personally follow every patient, or we offer them the opportunity to follow every patient year on year after that. Echocardiography it's done well in pretty much anywhere, right? But when it comes to actually looking at, very specific measurements on the valve itself and very specific changes over time, we will typically go ahead and perform the echo and look at that in the same hands or the same set of protocols going ahead. And that way you can notice changes over time if the valve is degenerating slightly, or the gradients are getting higher over time. You can maybe follow someone else up a little quicker than that. But follow-up is very important. Education as to symptoms. Patients will often say, well, what will I notice? One thing we often tell patients, they used to be this thought that if you go after the procedure and you were to suddenly start jumping or running around, that the valve may come out. And so we tell patients, no, if that could happen, that valve is not put in correct. Yeah, I tell them specifically, if you were to skydive out of a plane, all your bones should be broken, but that valve should probably still be in the aortic valve. So that there's things like that. Cardiac rehabilitation is still often advised for many patients that had the procedure to be looked at afterwards, and they can undergo the same rehabilitation process that patients that have a stent or have a heart attack, or there still may be some benefit to those patients being followed up after that. And then after that, every year, if the shortness of breath comes back, if the tiredness comes back, if other things like that can be looked at over time, and then you can have what we call a longitudinal follow-up and pick things up early. One thing we do in our clinic is we have a sheet of 20 parameters that each time we fill them in, and one of the things we do in each visit is compare the direct things on the visit to the direct thing before, and you can pick up earlier problems then.
Very good. So tell me, Mustafa, what is the future for TAVR? Are we there yet?
If you had asked me 10 years ago, what's the future? You never could have predicted what's happened now. I mean, it's mind-blowing. A surgeon I worked very closely with told me that 15 years ago or 12 years ago, someone came to him and was like, hey, we've got this valve, like, you really want to try this? This is great. And he just looked at them and laughed and was like, there is no way that you should ever come back to me with that nonsense again. And it's ironic because that surgeon is now one of the highest volume TAVR implanters, and he is the biggest believer in it. But what's funny is how much of a bigger believer he is in all new technologies, because he says, I just can't believe it. I cannot believe that happened. And so if you'd told me, like you say, patient come in, what is the future? I mean, the only way to kind of accelerate at the same pace we have in the last 10 years is to go to someone's house and perform the procedure in the middle of the night so they wake up with a new valve. I mean, that's really the only way to recreate the last 10 years of progression. But you can always do better. We can always try and make things zero. How do you move towards where stroke just isn't a possibility? Vascular damage doesn't happen. You make it such a routine and slick and advanced procedure that complications become a minimum. So I think the next area, the future now is going to focus on how do we increase durability? How do we know exactly which valves are going to last longer and not last longer? How do we pick the perfect valve for each situation to last even longer than that? But there's this valve in valve come along. So a lot of the procedures, I'd say for us, as a referral center, maybe 15% of the procedures we do are inside valves that already have a valve. And so what's amazing now is you can actually crack the old valve open. You can crack the frame and put a newer valve. And so you can get a larger valve in than people were able to put before often. And so that also is advancing and saying the future. But there's another sobering aspect of the future which needs to be thought about as this technology explodes. Now, people will know this because when we put stents in, and Dr. Bouchard, I know you know this as an interventionalist, and other people listening will know, you'll come across those patients where you say, who on earth put those 100 stents in that patient's like 50? What's going on here? We can't operate on that patient anymore. Why was that done? Why was the correct decision not made not to do surgery at that time, or whatever it was? And the dilemma we're going to face in TAVR, depending on the way it's governed, is what happens with the low-risk patients or intermediate-risk patients in 10 to 15 years. The good news is we've done lots of valve and TAVR valves, as we go out those distances. They've been done well. But what about if you need to get back in the arteries? What if you need to be able to put a valve inside a valve inside a valve? As the experience with TAVR grows, I do worry a little bit about surgical experience. The surgeons, I call them the old school surgeons that were just, no matter what you give them, you can handle the situation. What are we going to do if, there's 2 TAVRs in a patient already, but their only other resort is an operation? And so technologies that come along, is it conceivable to think of ways of removing valves, ways of putting in newer low profile valves inside valves, or newer delivery techniques? Can we get the tube that we put the valves in from being like as big as a pencil down to even smaller than that? So we call it French sizes. What used to be 24 French, then became 18 French, then became 16, then became 14. But as we get smaller and smaller, there's trade-offs with the actual, engineering of the valve itself. And so striking the balance between all that's going to be the future. And, as you talk about more concept work, how do we fix the aorta? At the same time, what do we do with patients with a large aorta? What do we do with, like you said, the patients with regurgitation? How can we get the pacemaker rate down to 0? Is there going to be valves that come out in the future with little implants in them already? Is there going to be bioengineering that allows us to pick up the generation much earlier? And those are the exciting things that are going to happen with the space. It's a remarkable space and technology, and new upon new things are coming out. And the other important bit of the future is, do we just take all patients one day that have moderate to severe aortic stenosis and find a treatment that's, so low risk that we should just justify treating everyone with it? And that, you'll find trials and research will come out with that. So in 10 years' time, we should have the answers to those questions too.
Well, Dr. Ahmed, thank you very much. The TAVR procedure, everything you wanted to know. Dr. Ahmed from the University of Alabama Birmingham, thank you very much.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.